false positives and true negatives.
There is a reason as to why I said we shouldn't always consider the accuracy of the model alone. We are going to have an example. So let's have an example. Yeah, we've recently had COVID, the pandemic. Maybe you want to train a model to predict the person with COVID or no COVID. And you collect, and here with this example, you're going to see as to why you should always have a balanced class. So in this example, you collect chest x-rays, and you have 9,900 health chest x-rays of people with no COVID. And you also have 10 x-rays of people with COVID. Remember, based on this formula, we said accuracy is just a number of total correct predictions divided by the total number of predictions. So in this example, the size of the data set is 10K. And you have two classes, that is people with no COVID, which is 9,990, and people with COVID, which are only 10 cases. So if a model you train and the model says the person has no COVID, to derive the accuracy, we shall make to calculate accuracy, we shall get the 9,990 divided by the total number, which is 10,000. So the answer, you will get that your model has an accuracy of 99.9. And if you're a starter and if you've just joined machine learning and you train, this is your first time training a model, and you check the accuracy, it says 99.9 accurate, you'll be very excited and very happy. But this model cannot perform well. In other words, every time you use this model, it will say no COVID, no COVID. It will make a prediction, no COVID, no COVID, no COVID, because it has an accuracy of 99.9. Yet in actual sense, there are 10 cases of people with COVID. So it's always not good to depend alone on the accuracy of the model to deploy your model to production. So another way how we can calculate accuracy, like I said, we can use the confusion matrix. To calculate accuracy, you can just get the true positives plus the true negative divided by the rest. That is the true positive plus false positive plus true negatives plus false negative. With this formula, you can get accuracy from the confusion matrix. So that's why I said much of the focus should be in understanding the four terms. That is the true positives, true negatives, false positives, and false negatives. So now let's look at what we call precision. So precision is one of the indicators of machine learning model performance to check the quality of positive predictions made by the model. So precision is all about you checking the positive predictions made by the model, and it is given by the formula true positives divided by the sum of true positives and false positives. Okay? Remember, these false positives are wrong predictions made by the model to classify a person with, in our example, to be having cancer, yet in actual sense, the person has no cancer. So precision is just an indicator of the machine learning model's performance on the true positive predictions made. So it focuses alone on the true positive, and it's given by this formula. We have what we call another metric. We have what we call recall, or the other name of recall is what we call sensitivity. So sensitivity is just a ratio of the number of true positive samples collectively classified as positive divided by the total number of positive samples. So you have collect predictions made to be positive over a number of over a summation of the positive samples. It is given by the formula true positives divided by the summation of true positives plus false negatives. Remember, these false negatives are positive because based on the definition or based on the formula that we gave, false positives, these are predictions made to be by the model to be negative, but in actual sense, they are positive. In our example, there will be patients predicted to be not to be able, patients predicted to be without cancer, but in actual sense, the patients have cancer. So they are positive. So recall what we call sensitivity. It is a ratio of positive samples classified collectively against a total number of positive samples that you have. So it's given by the formula true positives divided by the summation of true positives and false positive. And still on this, I'm going to give a scenario. When you check on the recall or sensitivity of the model, for example, if your major target of training a model is to predict positive classes, for example, if you're training a model and you want to identify all people with cancer, in our example, all people with cancer to be predicted right that they have cancer, you should always look at the recall or the sensitivity of the model. So the other name of sensitivity or recall, it's called the true positive rate. So you may find in an assignment towards the end that I've given, maybe I'm asking for the true positive rate. So the true positive rate is the same as what we call sensitivity or recall. We have what we call specificity of the model, and specificity measures the portion of true negative classes predicted to be right versus all the negative classes that you have in your data. It's given by the formula true negatives divided by the summation of true negative plus false positives. Remember, these false positives are negative. They are wrongly classified to be positive, but in actual sense, they are negative. So when do we use specificity, or when you check on specificity of your model is, for example, if your goal is to predict patients without a disease, maybe cancer or no COVID, definitely you should always focus on specificity of your model. In other words, it helps you to capture all patients, all people predicted to be without a disease if you're training a model to predict a disease. So specificity will be able to capture all patients without a disease. So if your major focus or your major focus of the model that you're training is to classify people without a disease, definitely you need to check out the specificity of the model. It's also called the true negative rate. So that is the other name of specificity, the true negative rate. Then at least we've seen what we call recall or sensitivity and precision. So why do we care a lot about these? So much focus, when you look at precision, your much focus should be on minimizing the number of false positives. Because remember, false positives, they are always negative. they are wrongly predicted to be positive, but in actual sense, they are negative. So your major goal with precision is to always try to minimize the false positive values. And on the other side of recall, you should always try to minimize what we call the false negatives. So we have a metric which is very much important whenever you train a classification model that you need to look at. It is called the F1 score. So it is one of the most important evaluation metrics in machine learning, since it is a combination of precision and recall. So if the value or if the score of F1 score of your model is 1 or 100%, which is very rare to get, then your model is perfect. But if it is 0 or closer to 0, then definitely your model is not performing well, it is failing. So it's given by the formula 2 into brackets, a dot product of precision and recall divided by the summation of precision and recall. Definitely, you know the formulas. You can go back and derive the formulas of precision and recall. So we have another metric called the Murphy correlation coefficient. And this is much important when it comes to scenarios where you have an imbalanced class. So the Murphy correlation coefficient is derived with this formula. You just get the dot product between the true positives and the true negatives minus the instances which are false. That is a multiplication of false positives times false negatives divided by the square root of everything. So definitely you can derive this from the confusion matrix after understanding the 4 elements. That is the true positives, true negatives, false positives, and false negatives. Then let's cross to the side of some bit of the curve. We have what we call the receiver operating characteristic curve. And it's always a graphical representation of the true positive rate and the false positive rate. Whenever you have an imbalanced class, you need to check out these metrics. That is the Murphy correlation coefficient, and you need to do the plotting of this curve. This is just an example of the curve. You can much focus should be on the area under the receiver operating characteristic curve. When you do the plotting, you should focus on area under this curve. Or this is another example. The much focus should be put on area under the curve. So we have another curve that you can also focus on, what we call the precision recall curve. And all these curves, you must pay attention to the curve, or you must plot these curves whenever you have an imbalanced class. Yeah, that's some. I've come to the end of the presentation on the evaluation matrix for classificational models that always you need to look at. And I've the last 2 slides I gave a case study to try to test out whether you've understood the 4 elements of a confusion matrix. That is the true positives, false positives, true negatives, and false negatives. So that marks the end of the presentation. Back to you, Victoria, if there are some questions in the chat. Victoria? Okay.
All right. I assume you can hear me now.
Yeah, I can hear you.
All right. For some reason, my mic refused to pick without my earphones. I'd remove the earphones. All right. So you have a lot of standing ovations in the form of claps. Thank you so much. We do have some questions, and I will be the case study that you've given. I will be uploading that as part of this week's work. But in the meantime, the questions that we received are three of them. I think one was just a correction. There's a point you said false positive when it was actually true positive, but that was responded to. So the first question that was asked by Rosina is, how do you know the model is under or overfitting?
All right. To the person that asked the question, thanks for the question. How do I know that my model is overfit or underfit? I will start with overfitting. If you train your model, for example, and you get an accuracy of 100%, definitely your model is overfit. And what do we mean overfitting? Overfitting is when your model is performing very well on your training set. You remember, divide the data into 3 different sets, and definitely you try to evaluate even the test set, the validation set, and the test set itself. You try to calculate these metrics that we've gone through. You will find out that on your training set, the model is performing very well. Be it on accuracy, be it on maybe you've calculated precision, sensitivity, the model is performing very well. But when you switch to your test set, the model performs terrible. That means that is a clear indication that your model is overfit. And what does it mean? It means that the model, during your training, the model didn't learn. The model was just cramming the data that you're giving it, and it's not learning. So definitely that's why it is performing poorly when you introduce a new set of data. Because when we say get your data set, divide it to train, validate, and test, which means the data that's used for training, already the model has seen that data. But the data that you use for testing and validation, it's going to be like a set of new data sets that your model has never seen. And it is seeing it for the first time. And if it performs poorly on that data, just know the model is overfit. In other words, the model didn't learn it. It was just cramming during the training. Then, on the side of how do I get to know that the model is underfit? Definitely, the model is performing poorly on my training set itself. It can't make prediction. For example, sorry, let me share my screen again. For example, if you come up with a confusion matrix, you find out that you have less value. Let me put to presentation mode and get a pen. How do I get to know that my model is underfit? You find, remember, these are the true predictions made by the model. I'll just give an example. If I have a data set of just 100 records, after training, I plot I plot the confusion matrix. These 100 records will be divided. You find maybe you have 10 here, and maybe you have 5 here, and the rest of the values fall. Maybe you have, this is 15, I'm left with, you have 45 here, and you have 40. So definitely, I'm here looking at this, the model is underfit. The model can only predict true, positive values on 10 out of the sample, and can only predict negative value only 5, and it's making a lot of mistakes. The model has made mistakes 40 times to predict values which are false, which are negative, and it's referring to them as positive 40 times, and the values which are positive 40. The values in actual sense which are positive, they are 44, and the model is saying they are negative. So the model is underfit based on just even the test set itself. So the model is underfit. Let me hope I responded to that. Back to you, Victoria.
Thank you. I'm hoping I'll take a look and see whether they understood that. The second one was, the second question is, does ground truth mean establishing a gold standard for diagnosis?
Ground truth means, yeah, it may be, it's 50-50. Ground truth means that you're doing your labeling and you are 100% sure with in this example of the virtual training, you have an expert, the medical personnel, and he tells you, okay, this scan is of a person with cancer, and these are the regions with that are cancerous. Ground truth, you label it cancer. So it's a standard of measure. After training, you look at the ground truth, the actual truth, and what the model is predicting versus what the model is predicting.
All right, thank you. I think the previous one, Rosina indicated she was okay with it, or he was okay with it. Sorry about that. The other question is about true positive and true negative being part of the confusion matrix. I'm thinking you might have answered this during your session, but maybe just say 1 or 2 sentences. Why true positive and true negative are part of the confusion matrix? This is the right diagnosis.
Okay, let me just run through again the true positives a little bit, but I never understood that question. But
Yes.
let me share my screen.
And maybe Rosina can indicate that part where you're saying this is the right diagnosis. Kindly also note that Ross has also added that in the diagnostics, they call ground truth the gold standard. So that was
Yes.
also responded to by Ross.
Okay, so on this side, you have the actual truth, the ground truth. And on this side, you have the predictions that are made by the model. So after training, then you try to compare. And I said much focus. If you see much of your value that they are falling under the true positives and the true negatives, that means that the model is performing well. So this other corner, that is the true positives, that is the false positives and the false negatives, are wrong predictions, are wrong classification the model is making. That's why in this example of having maybe 100 records, if you have, for example, 40, if the 45 is here and the 40 is here, and you only have 10 this side and maybe 5, then your model is performing well. In other words, these values, that is the false positives, are wrong predictions made by the model. And the false negatives are wrong predictions made by the model. And our goal is to train a model to be able to make right predictions. So false positives and false negatives are part of the confusion matrix, because definitely the model is going to make some mistakes. And that's how you get to know. And that's how you get to evaluate its performance based on the mistakes it's making. If it's performing well, there will be less mistakes in a layman's understanding. There will be less or fewer mistakes if it is performing well. Back to you, Victoria.
Yeah, thank you. Rosina has indicated that she's that they have gotten it. I don't know, Rosina, for some reason, the name has stuck in my head as being of a particular gender. All right, so the next question was when you were discussing the overfit and the underfit, somebody asked, and this is Victor. Victor asked, so does it mean when the model is overfit, the data is not accurate, and when it's underfit, it is accurate? Please give some more clarity.
No. When the model is overfit, which means the model is just cramming on your training set. And one of the reasons as to why the model might be overfit is using a complex algorithm on the model. So you need, one of the things is you start by changing the algorithm that you picked for training your model. But if the model is underfit, still it's not good. The model is performing terrible on just your training set. So you need also to change the algorithm that you have. And last time I talked about I talked about the model parameters and the hyperparameters. So definitely, one of the things is to change the hyperparameters of your model that you're having. You try to play around with the hyperparameters and you evaluate the model again and you see how it is performing. Underfitting and overfitting is bad. We need a model to be generalizable, to perform well on your training set, and as well to perform fairly well on your test set on the data that it has never seen. It should be able to perform fairly well on it as well. That is a good model. That is what we call a generalizable model. So the model should be generalizable. It shouldn't be underfit and it shouldn't be overfit.
All right, thank you. And Victor, please also look, there is an additional response from John. We have a last question from Clifford, from Dr. Clifford, and asking what would you recommend as the appropriate portion of training data relative to validation and test data in terms of positives and negatives to achieve the best model performance without overfitting?
Okay, so I'll start by saying one is you need to be careful on the size of your training data. If you're dealing with medical images, like the way I said, at least you should have a minimum of 1,000. And if you have a minimum of 1,000, definitely you need to spare like 700 of that data. You use it for training, and maybe 100 you spare it for testing, and 200 of the data you use it for validation. So you could look at a percentage of 70 training, 10 testing, and 20 for validation, in that order. But you should be very careful on the size of the data set. You should find means of finding enough data to train the model, because the model is not going to learn at once. And remember, there are always different scenarios that can happen. If I'm to use the example of breast cancer that we've been using as an example, even the size of the breast will change based on the scan that is done. You may find a woman, the breast is big, another one is small, another one is medium. So you need to capture all of those variations in terms of collecting much data to give the model to learn. So be careful on the size of the data set that you're using. Back to you, Victoria.
Yes, thank you. And then one last question just came in. Mohammed is wondering if this trained model on images, whether it will start hallucinating or not.
Trained on images, there will be no hallucination. Hallucination is making generating. This is what we've discussed is on the discriminative machine learning, and hallucination happens on generative machine learning, the other side of the LLMs. So if you trained a model, or what we try to refer to the traditional machine learning on images, definitely the model cannot hallucinate. It's either it's going to make a false prediction or a right prediction. It can't generate a different image. Thank you.
All right, I think that answers that. And it seems Dr. Clifford had an additional question. And I think this is the last question we'll take so that Ross can come in. How do you proportion the actual negatives and positives, i.e. the data for ground truth?
That is in terms of the number of the data sets you collect. You have to balance. You saw an example where we talked about COVID, where we had X-rays 9,990 for health people without COVID and only 10. So definitely you need to balance. You need to balance your the classes in your data sets. And this is just an example of binary. You may find out you have more than 2 classes. Maybe you have 4 classes in a data set. You need to balance, at least to avoid scenarios where the model is only predicting from just one class. You just have to balance the data set.
All right, thank you so much, Henry. I think we can all give him a round of applause, perhaps just use the reactions. I think you should be able to see those. Henry, I think you can see those on your screen, I hope.
All right, all right.
Yeah,
Thank
thank you so much for that. There's a clarification I wanted to make before Ross comes in about the registration link. It's shared every day. Everybody needs to register so long as you're among the teams that were selected for the class. So we expect you to register. I know somebody asked, we confirm what the link is for. It's to show your attendance of the class. All right, so the link has been shared. I think you should see it. In case you don't, just let me know on the chat. All right, over to you, Ross.
Thank you, Victoria. So I'm going to share. Can I share my screen? Oh, are you sharing or is mine?
No, you as just share on your.
Okay, can you see it or not? No.
Not yet.
Not yet. Hang on a minute. Share. Okay, can you see it now?
Yeah, it's loading. Yep. You can see it. And they can see it too. I got a thumbs up.
Great. So we're changing tack a little bit. So this will be a bit more comfortable for the medical people in the room and a bit less comfortable maybe for the computer scientists in the room. But it's an important topic that we need to think about moving forward.
It's showing Ross, I hope you can hear me. It's showing the presenter view, not the slideshow. It's done it in reverse. So your other monitor has your main, and then we are seeing the presenter view. Yeah.
So what do I need to
close it?
Hang on a minute. Hang on.
And then just make sure if there's a place normally you can change that so that the monitor that it displays on is the
Now is that working?
Now we can see it.
Brilliant. Okay, so the learning objectives for this session are to introduce the following concepts, and they're concepts because we are going to touch on these things rather than going into deep dives. So we're going to have, I think, about principles of inequality and equity, which are important principles when we're thinking about providing healthcare, healthcare provision and global governance for health. We're going to have a think about examples of AI-driven innovations, less on that. I was going to include some examples from the HASH project, but I think you guys already have quite a few examples. But we're going to think about the human rights implications and ethical considerations in AI and health, and a bit about the policies, mainly focusing on Africa, because that's where I know, but maybe we can have a discussion about those in Asia, in Pakistan and Nepal as well. So this graph is really talking about life expectancy over time. And on the left-hand side, we've got these numbers, which is life expectancy at birth. I'm just thinking if I can get my laser going. Yeah. Okay, great. So here is the life expectancy at birth. And this is looking at the world's population along the bottom. So this is the total population. And this is looking at over time. So the red line is 200 years ago, or actually 300 years ago. The yellow line is about 70 years ago. So the improvements in life expectancy at birth from 70 years ago, and then what's happened in the last 70 years up to 2010. And what we're seeing is that some places, are still struggling down with very, very low life expectancy. So, 300 years ago, the highest life expectancy was still only around 40 years. So when you were born, you only expected to live on average to around 35, 40. Right now, in high-income countries, you would expect to live to around 80. But in lower-income countries, the incremental changes have been less. So there's still life expectancy less than 70 years in a large proportion of the population of the world. 50% of the population of the world expects to live to 70, and the highest income brackets would live to about 80. Now, what this is trying to show, and I just want to alert your minds to this very, very good website called Our World in Data, which is if you want to get good data on the state of the world, especially in health, but in other things as well. This is very good validated data that you can use for projects, for reports, even some data can be downloaded to integrate into kind of multimodal AI models. But the other thing that I wanted to show you is that life expectancy on the whole is increasing everywhere. However, there is still a huge amount of inequality. So if you are a baby born in the Central African Republic today, you can only expect to live to be about 50 years old. But if you're a baby born in Japan, you would expect to live to 86. Okay, so I'll come to why this is important in a bit. Okay, so this inequality exists. Some of this mortality is to do with poverty, global health inequalities that we'll be talking about in a minute. But some of this is to do to access to healthcare. So when we look at this map, what this is trying to do is look at access to quality healthcare dependent on mortality. So it's measuring the mortality that happens purely because of lack of effective medical care, not because of any other factors like, temperature or disease burden or genetics or all of these kind of things. This is really trying to extract out the healthcare. And what we see is that there is a huge amount of inequality. And in our areas that we are coming from, so from Southeast Asia and Africa, we are suffering the most from inequalities in access to healthcare. And this is causing us huge amounts of mortality that isn't happening elsewhere in the world. And so what are the other reasons for global health inequalities? So lower middle incomes are suffering because of the joint problems of poverty and debt. So they're poor countries, but they also owe a lot to other richer countries. And this is, hamstringing them in terms of spending money locally because they're paying back debt. They have weak health system infrastructure. And the last slide was showing that, how the health infrastructure is leading to excess mortality. Resource and capacity constraints, aid-led vertical programming. So, for example, HIV has got much more share of the pie than other diseases such as malaria, non-communicable diseases. But there is interaction between these diseases. So HIV and TB leads to greater risk of death from TB, malaria, and other neglected infectious diseases. And increasingly, a burden of disease between non-communicable disease and infectious disease, and increasing non-communicable disease on its own. So increased amounts of strokes, heart attacks, respiratory problems, asthma, many more non-communicable disease issues, a lot of increase in cancer as well. So that is from a global scale. When we look across the globe, there are inequalities, right? Higher resource settings have better health and better outcomes. But even within countries, there is inequality. So what this is trying to show is give some examples of, even in richer countries, how within different populations there is inequality. So for example, in Russia, women live on average 12 years longer than their menfolk. And that's a gender-based inequality. Other places, women die more, often driven by maternal mortality. And we can see this in the UK. In the UK, if you are a Black woman in the UK, your risk of dying in pregnancy is much higher, over 20 times, over twice as high as if you're mixed race, and over 5 times more likely to die if you're Black than if you are white. So even within high income settings, there are differences between minority populations. In Canada, rural populations are at risk of health inequalities. So what this is showing is Indigenous Canadian populations in Black and where people are living, and the road network in red. And you can see here there are huge numbers of populations that are not served by good quality road networks. Therefore, their access to healthcare is limited. But then there's sometimes things that you wouldn't expect. So if you look at the prison population in the UK, men in prison are actually 2.5 times less likely to die than men of the same socioeconomic class that are outside of prison. So if they've got the same background, they live in the same communities, but either they're in prison or not, those people in prison are more likely to survive than those people outside. And this is likely because when they're in prison, they have access to doctors and nurses on site. They get their medicines given to them at a regulated time, and somebody helps them take their medicines if they need medicines. And they have time to prioritize their health because they've got nothing else to do because they're sitting in prison. Whereas if they were on the outside, they may be running around trying to get money, do their jobs, whatever else they're doing, and not prioritize their health. So sometimes it works in a way that you wouldn't necessarily understand. And what this altogether means is that when we are looking at data and when we are looking at AI and when we are looking at developing solutions in our context, we have to take these things into account. We cannot just come up with, as our computer scientists going, I've got a really good idea that is going to be able to help men access healthcare services. We have to think about those challenges that those men might have. Are they a group that lives longer than other people? Are they men that take more alcohol? Are they truck drivers who spend a long time traveling away from home and can't get access to healthcare? Are they men that are cycling in and out of prison? Are they army people that are based somewhere else? Are they people who are very stigmatized and can't get access to healthcare? So even when we're thinking of solutions and AI solutions for particular populations, we have to drill right down to seeing what is best for this population. And what we are then looking at is the difference between providing health equity and health equality. So I'm just going to take you through this at the moment. Say we take our bicycle as our AI tool. So say you think of the bicycle as an AI-enabled tool. Health equality would be that we would give the same AI-enabled tool to everyone, to the disabled person, to the man, to the lady, and to the child. But as you can see, the lady in the wheelchair can't even get on the bike. The man is too big for the bike. The lady, actually, it's working quite well for, and the child is too small, okay? So when we think about this in an AI context, we might say, okay, but we've given an AI tool to everybody in the village. Everybody should have access to this tool, right? But this tool is a web-based platform that requires you to have a smartphone. So we are making the tool available to everybody for free. But if everybody doesn't have a smartphone, if everybody can't get on the bike in the same way, we are saying that we are giving them a tool that is based on equality. But what we haven't done is move to health equity. So what health equity is this tool, this bicycle, is adapted and is responding to the actual needs of that population. So for the lady in the wheelchair, it's adapted for her so she can use her arms. The man has a bigger one. The lady is doing quite well on hers, and the child has an even smaller one. And in our context, what this could mean is for a visually impaired person, they get a conversational agent, for example, that can do speech and can talk to them. For somebody who is a healthcare worker, they can get a conversational agent that can talk to them in technical language and push them to guidelines and information that they might need. For a pregnant lady, it might be giving her information that she needs about pregnancy, and it might be on an analog phone because women have less access to phones than men. It might be an analog phone where she can get text messages. And for the little boy, it might be a computer in his school. Maybe he can't read, so it can talk to him, but he may be able to access our conversational agent, our AI agent at his school. So what we need to think about when we're developing AI tools is this concept of equity, not just how good our tool is. It doesn't matter if we produce the most beautiful, all singing, all dancing health AI solution, if the people that we want to get it to aren't able to access it. And so from the beginning, we need to be thinking about these things. So I'm just going to switch you over to a Mentimeter now. And what we're going to do, I'm going to, I'm going to stop sharing above, which I'm now struggling with. Right, Vicky, what am I doing wrong? Let me go back up to...
Back all the way at the top, there should be stop share.
Yeah, what I've accidentally done there is got rid of my...
All right, let me stop it for you, okay?
Yeah, can you stop it for me and then I can switch over what I've
There
done
you
is...
go. Now try.
Okay, thank you. Okay, so now I'm going to share My Mentimeter. Right. So can you see the Mentimeter code? Or not? Are you seeing the Mentimeter code, or are you still saying
Still seeing you.
still seeing my slides?
No, not the slides. We are actually just seeing you. The slides stopped being shared. So
Oh,
yeah, start
okay.
again. Yeah. You have to go to share and then share the
You know, guys, I'm just going to tell you something. So I do a medical drones project, and Vicky's heard this before, but I do a medical drones project in Uganda. And my children routinely say to me, Mum, how can you possibly be allowed to run a medical drones project when you don't know how to work the TV? And that's how I feel a little bit on doing this at the moment. How to work the Mentimeter. So I'm hoping that you guys can now see the code.
Yes, we can.
And I'm hoping that if you've joined on, you can go to the next screen, which is, what do you think that we can do? And I would like everybody to put in one answer at least. You can do more if you like. But what do you think that we can do as researchers, as innovators, as computer scientists, as doctors? What do you think we can do to address fairness in AI? So just from what you've heard about, let's talk about fairness, let's talk about equity. How can we increase equity and fairness in this? So co-creation, fantastic. So we've only got 17 people on the Mentimeter, and we've got 80 people on the group, right, Vicky?
Yeah, I'm just sharing the code on chat. I'm hoping they'll be able to join. So in case you don't have the code, please, there is the code. Just go to menti.com and put in the code.
So somebody's got their hand up. Yeah, Israel, do you want do you have a question? Or are you struggling with the code?
Yes, I wanted to respond to the question, but I noticed we are to respond on the Mentimeter.
If you can. And somebody's put this here, processing data, why you want to process personal data helps to keep it fair. Yeah.
So if you can, please put all your responses on menti.com. So Yoti, I'm not sure that I'm pronouncing your name well. If you can just type that into Menti. Yes, let me post the link for you. 1 second.
Okay, do you want me to go back to, should I go back to let me go back to the QR code, because you can copy the QR code as well. Can you see the QR code at the moment?
Yes. All right, I think you can now go back to the question. Yeah, there you go.
Okay, so let's have a look at some of the answers. So co-creation of projects, locally trained models, use of local data from different populations, diverse data set, diversification, community friendly, availability. I don't know whether that's availability. I think probably availability of the tools. Responding to needs of the individual, specify the problem for different clusters of people. These are all excellent. Public awareness, transparency, localizing the AI, multidisciplinary teams, ethics in the modeling, continuous modeling and clear accountability. Governments to support AI projects because we don't have profit-based financing that's fostered AI development. Yeah, so who is going to pay for this? What is the sustainability of this, and how do we make sure that it's available to the people, mitigating biases, conducting auditing, continuous education, inclusive data sets, really excellent responses, consultation of diverse populations, monitoring and auditing of the AI, and transparency. Okay, so I think I'm going to stop sharing this for a while. We'll come back to analyze it in a little bit. And I'm going to go back to sharing the PowerPoint slides now. So can you see the... We can see the slides now, right? So just to summarize some of the things that you've been saying, and we'll talk about bias in a minute, but this is trying to, and I can add a slide of harnessing your really, really great comments so that we can capture those as well. But here's a kind of summary slide that I did before your fantastic comments, looking at this. So inclusive data collection, diverse data collection, representative data sets. You guys talked about this. Community and stakeholder engagement, involving patients, healthcare workers, marginalized groups in all cycles, all parts of the cycle. So design, testing, and deployment. Contextual adaptation, so we talked about this, tailoring the tools to local health systems, cultural settings, and resource availability. That talks about the government resources. What are the resources available? Can we afford to do this? How can we do this cheaply? Capacity building, training the local teams. And of course, this is what we're trying to do at the moment, is really build capacity within our own ecosystems so that we have researchers and healthcare providers who are up to speed on what we're trying to do, including the ethics of what we're doing. And transparency and explainability, ensuring that AI systems can be interpreted, and somebody mentioned this transparency, making the decision processes clear on how tools are developed. So really excellent feedback from yourselves related to this. So now what I've got a challenge with is my slides. Here we go. So we're now going to move on to kind of the bias type thing and the ethical kind of challenges. And I'm not sure why this has happened. I think perhaps because it was originally in a PDF. But I'm sure you guys have done this before, which is to try and create pictures of different people. And still, things are getting a bit better. I did these about 6 months ago. And I tried to do a few more again recently, and things have improved a little bit. But in these images that I generated one of a nurse, one of a doctor, and one of a patient in hospital. Each one of these was a white person. The nurse was a young lady. The doctor was an old white man. And the patient in hospital was also an old white man. And this is just one simple little example of biases that are already inbuilt into our models that we are downloading, for free, especially the free versions. They are taking what is from the web to train their tools. What is from the web is skewed to high income Northern European and American countries, especially when it comes to English. So we need to be aware that the data that is readily available, that is routinely available through different systems that we are using and different tools that we are using, is very, very, very biased to the global north. But we also, okay, so I'm really sorry, my slide animations have disappeared again. I'm having technical issues, which is slightly embarrassing. But I wonder if I can. I wonder if I can just stop the slideshow. Well, maybe we can look behind. So if you try and ignore the big star in the middle, what this is trying to show is study data from the United States. In fact, what I am going to do is just stop the slideshow and get rid of that big star in the middle. Okay, and then redo the slideshow. Okay, so what this is trying to show is American data. This is US data, okay? And on the left-hand side, it has the actual medical conditions and the life-adjusted years, which is the amount of burden of disease for American women of different types of medical problem. So the greatest burden of disease is musculoskeletal and trauma, but we've got psychiatric, cardiology, neurology, oncology. So this is diseases and types of disease that affect women. What we have here is the gender balance of studies that have recruited both men and women. And what we have on the left in the orange is the number of women or the proportion of women enrolled in the study. And what we have on the right-hand side in the green is the proportion of women compared to men that are affected by this disease. So if we look at this top one, which is musculoskeletal and trauma, we have about 47% of people enrolled on musculoskeletal studies are women. Yet, nearly 60% of all of the people that have musculoskeletal diseases are women. So therefore, there's a big disconnect between how many women are enrolled on the study and how many women are actually suffering from the disease. When we look at cardiology, it's even worse, okay? So women are disproportionately affected by heart problems in the States, but they're also very, very, very lowly recruited onto studies. So generally, if this is 50%, we are recruiting less women than men onto studies. But it's really striking that in some conditions, we are recruiting less women than men, yet women have more. And what I'm trying to show with this is even with American data, the research data that we're basing our AI tools on is already skewed from the beginning because of years and years and years of under recruiting or not equally recruiting men and women into studies. Now, that's just men and women. When it comes to minority populations, people of Black, Asian, Middle Eastern origin, children are hardly ever enrolled into studies because there are ethical concerns about putting children into studies. But then if we want to make AI tools that are going to help children, we don't have any data on them. And yet they're very, very different to adults in terms of the way they metabolize drugs, their body size, how much energy they use, how big their brains are compared to their bodies, so many different physiological things. And yet we just don't have data on them. And so we really need to be very, 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 very careful about these intrinsic biases that are built into the things that we are trying to build. And so here's some more examples. So HIV data sets will actually overrepresent women, because certainly in Africa, men do not seek HIV care as much as women do. And what we found in our data sets in Uganda is that almost 60% women, sometimes nearly 70% women. Children are underreported. But then there's these other things. So if you're in a health center without power, you won't generate electronic records, right? So how does your data, if you're in a low-level health center, how does your data get into the database to enable us to develop a tool that is related to you? So what's the implication of this? So it can result in diagnostic errors if we're generating AI diagnostic tools. It can result in unequal treatment, and it can deepen these health disparities. And what our real challenge is, real big challenge, and what the reason why I'm interested in AI is we really need to think about how we can make sure that AI doesn't increase our inequalities, and it helps to close the gap in health access and health inequality and not increase it further. There's also this other problem. Again, we've got an issue with our slides, sorry. So what I was just showing on the screen is some cards from South Africa. I don't know if we have any South Africans here, but in South Africa, they have shoppers cards where they get a loyalty discount for going to a shop. Now, one of the big concerns in different places is that once we start doing multimodal work and we start bringing sources of health information together from different places, it could cause us problems. So, for example, let's think about the shopper who has a loyalty card in South Africa, and they go into a South African shop and they buy a whole load of whiskey for a party. They also buy some cigarettes. They then get into their car. And because there's a lot of car theft in South Africa, they have a tracker on their car. And when they drive their car, they then go over the speed limit, and their tracker senses that they've gone over the speed limit. Okay? But then the next week, they then go to take out insurance on their car insurance. And their insurance provider has taken the data, or has managed to get access. He's bought the data from the shopping company, which says that this person is buying lots of whiskey. He has bought the data from the security company, which shows that this person speeds. And then when he comes to renew his insurance premium on his car, his insurer says, I need to triple your insurance because you are now a high-risk person, because I can see that you drink whiskey, I can see that you drive your car fast, and now I'm going to insure you, make your insurance much higher. So this type of activity could easily well happen. Now, it may be that he bought the whiskey for a party or presents for his staff. And it may be that his wife was sitting in the car park, and it was his wife that drove his car home. And he walked home, or he ran home to get some extra exercise. And he didn't touch the whiskey at all. And he didn't drive his car fast. And so he is being penalized as a result of data that is being used without knowing the facts of the matter. And this kind of thing is why we need data privacy and consent. That's just one example of when our AI tools get more powerful and they can analyze data from a variety of different sources, and people are selling data, private companies are selling data to each other. This can cause all kinds of problems. And if we think about patient data, then it becomes even more sensitive. People's HIV test statuses can be shared, people's cancer diagnosis. You know, I've read things recently in the UK where pregnant women have said that Facebook knew that they were pregnant before they did and started sending them pregnancy related, you know, clothing things and vitamins before they even knew that they were pregnant. So this kind of thing is a problem. And in low resource settings, people are not really aware of how they should keep their data private. And people are not really aware of the importance of giving consent, of taking consent, of how to share their data. And vulnerable populations are even more at risk, maybe because they have low literacy levels, maybe they have trust in the medical system, maybe, you know, they're just wanting the money. There was a company that set up in Kenya, right, Vicky, where they were on the streets, like encouraging people to come and have their iris scanning done. And people were given small amounts of money to do their iris scanning. And yet they collected a whole load of data alongside that. We have no idea what that iris scanning is going to be used for in future. But because it was a small amount of money and people trusted the system, they let their irises be scanned without perhaps knowing what that data was going to be used for in the future. So we really need to be careful that accidental breaches of data privacy, but also intentional breaches of data privacy can cause problems, but they can also are more likely to affect vulnerable populations, people that we as healthcare providers and we working in the health world should be protecting. And this is also a human rights concern. This infringes on the human's rights to privacy. So autonomy in decision making. I think this came up a little bit in some of your comments. You know, how can AI systems influence or even overrule healthcare professionals' decisions? We need to make sure that we are not letting our AI diagnostics replace our healthcare workers without adequate oversight from a human being. So one of the challenges is when you have such a high need and
Dr.
everybody's desperate for solutions.
Dr.
Are you okay?
Yes, you're not on presentation mode.
Oh,
Yes.
has it come out?
Yep.
Ah,
It took us back to your slides. Yeah.
yeah. Sorry. On my screen, it's showing that it is. Is it
Yeah.
now?
No, we can now see autonomy because it's gone to the next slide, but it's not on presentation mode.
Mm. What are you seeing at the moment?
Just a normal PowerPoint window.
You're still seeing a PowerPoint window.
Yeah.
So when I stop sharing, it's not coming off. I wonder whether it's so when I stop share, is it stopping sharing now?
Yes, it's stopping the sharing.
Right. So now when I go to this, we go to content only. What are you seeing now?
Presenter view. So what you did the very first time when you swapped them out, I don't know what that was. Yeah. We try going to slideshow and switching the monitors.
Yeah, let me do that. no, that's our Mentimeter now. That doesn't help you. Right. Okay. You know what? I might do just take off the monitors. We'll go to an old school.
Yeah,
An
one
old
monitor.
An old school solution, right? Okay, but you're still getting the presenter mode, right?
Yeah, no, we are actually just seeing the PowerPoint itself.
So now it's working.
The PowerPoint, the complete PowerPoint, not slideshow. If you actually just go to the slideshow itself,
Just keeps coming to.
good. You're good. You're good.
It's good.
Yep.
Now it's working.
Yep.
Okay. So, sorry about that. So if we are going to work with these tools in low income settings and low resource settings, the worry is that we're so desperate for help in healthcare situations, and we're so desperate for things that are going to help us, that we may just say, okay, you know what, we're going straight to using the AI tool. And we are already finding, and research studies have shown that people are already relying on tools more than they should be, and believing in tools rather than being skeptical about them. And the concern is that if there isn't transparency in healthcare decisions, who is taking the ultimate responsibility? It always should be a clinician to take the responsibility, because clinicians are the responsible body. If the AI takes the responsibility, what happens if some harm comes to somebody? Should that person, should the doctor in charge be the one who gets sued? Or should it be the AI manufacturer? And who do people complain to? Like, if people are very, very, very vulnerable, they may not be able to advocate for themselves. Not understanding how decisions are made means that patients don't have autonomy, and they are not making informed decisions about their health because they don't know what the options are. So we need to let people know when we're using AI. We need to make sure that there's oversight at all stages of development and monitoring and use. So, if we look in resource limited settings, there are many challenges around bias in our systems. Internet access is a problem, and so with many parts of the country, from an African setting where we are, but also in Pakistan and in Nepal as well, where so many parts of the country don't have access to internet, This means that they are not even generating digital tools. The picture on the left is a records department of a largest hospital. And this is where all of these paper records are. Frequently, when you go into these rooms, they're damaged by water, the rats have eaten them, they're ineligible, the pen might have faded over time. And until all of these records become digitalized, these people are not reported in our data sets. Their data and their diseases and their conditions are not there in their data sets. And on the right-hand side, what I'm trying to show here in this really crowded health facility is that, I don't know if you can see, let me see the pointer. I don't know if you can see this, this lady holding the medical records up here, and then there's medical records here. These poor nurses are trying to fill in these medical records in this environment. The quality of the data that they are collecting is going to be poor. There's going to be missing data. There's going to be absent data. I mean, this is one of the things that you guys are really going to have to work with and learn how to manage is missing data and inaccurate data, and how to manage data that's not complete, because you're not going to get beautiful, neat data sets, with thousands of records with no missing data that you can analyze. You're going to get data that's been collected in settings like this. And we're going to have to learn how to handle that, how to synthesize data, how to fill in gaps, how to handle this so that there are not biases generated by this. This is going to generate biases against the very people we need to help. Because if these women in this really busy clinic, data isn't collected properly, then these women in these very busy clinics will not be represented in the data sets. And then there's specific AI challenges around language for generative AI. So if you look at this, this is just trying to show lots of different African languages. And this picture on here with all these different languages on it, if you look down here, is less than 20% of all of the languages in Africa are shown on this diagram due to space. I know it's very similar in India. Many local different languages spoken, many different dialects spoken. But also, if we think about health language, different age groups, talk about language in different ways. Young people talk, for example, for sexual health that we're interested in and reproductive health. Young people's words for sex are very different to older people's words for sex. And one group of young people may have different words that they use compared to an urban group, for example. If they're living in a rural area, they may not be using the city words. We need to make sure that our AI is empathetic. It is quite good at empathy, but this is a problem that we need to think about with the AI. We need to think that it's not upsetting people and turning people off by using tone of voice, because we know that tone of voice and the way that people are dealt with in the health setting very much affects their access to healthcare. And if we have rare conditions, we need to make sure that there's accuracy of information, especially for very, very, very rare conditions. Henry was talking about having 1,000 records. If you've got a very rare condition that only affects 1 in 10,000 people, right? Over a population, that might be 3,000 people. But in a data set, it might only, of 10,000 people, it might only be 1. So how do we make sure that for conditions that are rare or situations that are rare, we are making sure that the data sets are accurate for those? So I wanted to do another Mentimeter again, but I think it's getting a bit late for us at the moment. So what I suggest you do is maybe if you can just in the chat, maybe you could just put in, rather than doing the Mentimeter, maybe you could just put in the chat your thoughts on how you personally, this is personal to you, what is going to be your takeaway from this, whether you're a doctor or a computer scientist? What's one thing that you know that you can actually do, not a theoretical thing, but you as a practitioner are going to do to help reduce bias? And if we could put those in the chat, that would be really great. Okay, so I'm not seeing anybody chatting yet, but it might be easier, unless you want to do it on the Mentimeter. Maybe some people have gone into the Mentimeter. No. So one thing, I'm not seeing any more comments. One thing that you can do, everybody personally, what's your personal takeaway? Yeah, brilliant, Jyoti. Thank you. What's your personal takeaway? The one thing that you're going to come out of this lecture and say, next time I think about my AI tools, this is what I'm going to do. So Jyoti is going to make sure she's got diversified training data sets. That's quite a big topic. Frank, using the electronic paper records. Absolutely, Frank. And making sure that we are encouraging people to fill in those electronic paper records. Auditing and testing models for unfair outcomes. Absolutely. That's at the other end. When we've got models that are working, we can audit and we can test them. Ensuring data privacy. Good. Calvin, I'm not sure how you're going to do that, but maybe you can do a follow-up thing of how you personally are going to ensure data privacy. Equity over equality. Well done, Peter. It would be great if you give us an example of how you might be able to do equity over equality. Israel, you published a research abstract that can help AI developers build responsible AI. So brilliant. Israel, maybe you can put it in the group chat, the link to your abstract, so that we can read it and learn from it. Yvonne's going to ensure confidentiality. Mohammed is going to make sure there's AI for all. Brilliant, Mohammed. Shiva is going to follow bias in the system, and Prasoon is going to integrate human review. Excellent. These are all good things, but together, and what I'm trying to show you is, as an individual, as a doctor or as a computer scientist, you don't have to do everything that I have put on the list, right? We all have different roles and responsibilities. Maybe you're the boss and you're in charge of privacy. Maybe you're the data manager and you're in charge of keeping the data confidential and making sure that your server has safeguarding checks on it. All of us have a role to play in this. All of us have a role to play in bias and fairness, but you don't have to do everything. That is why we need multidisciplinary teams. That's why we've asked you in the hackathon to work as a multidisciplinary team, right? And so we all have different roles and responsibilities within this. You don't have to get stressed that everything is your role and responsibility, but you have to make sure as a team, you are covering all of these activities. So Calvin has said, can AI be empathetic? Can we train it with therapeutic communication? Yes, so there is already quite a lot of work in the mental health space. A lot of people have done work on mental health work, and there's some good papers that have been published. And one thing that AI is quite good at, the generative AI, is really copying empathetic communication, and is actually quite good at talking to people nicely. Okay, so great ideas, everyone. And remember, you're a team to do this. So let me now see if, just for the last couple of minutes, I can share the last few slides. Let's see if the technology is working. Is it working?
No, it's back to...
No.
It's back to presenter. It's the other way around.
Is it doing that?
There's something
I don't actually know what I'm doing differently that's causing the problem, to be honest. No, not amenity. Working now?
Still presenter. I don't know why.
Because on my screen, it's not. Let me go into present. Let me go into let me try and go into it before I go into the Zoom. No, it's not letting me do that. No.
Do this. Close that. Okay, I don't know. I can't see. It's just frozen. And then under slideshow menu, just uncheck the presenter view. Maybe that will work.
Say that again.
Slideshow menu, right on PowerPoint, at the top, menu at the top.
Go to which one?
And then under monitors, there's something that says use presenter view. Maybe you can uncheck that and then just share. Probably will work.
Okay. Just ditch the presenter mode generally. Okay, is that working?
No, it's just showing the normal PowerPoint, but you can, there we go. Yes, now it's working.
Yeah. Okay. So, I mean, for this, you have the slides for this. So this is just summarizing what we've talked about in slightly more technical language. I think we've mentioned the diversity, we've mentioned the bias auditing, the context-specific validation. So this is something that we haven't discussed. And Henry kind of touched on it with underfitting and overfitting. But basically, when you take a model from one setting and try it in another setting, you can get discrepancies in that, you know, you can be on target for one population, but then when you move it to another population, it can, you know, underfit because it's just not designed for that particular population. So when we move these tools into new populations, we have to test them again. We have to make sure that they're working properly. There's algorithmic fairness techniques, which I'm sure you're going to be learning about, reweighting, resampling over the next few weeks. Transparency in the model development. So we need to document the way that we develop models. People need to understand how these things are done. We obviously can't get transparency into all of these black boxes that, you know, the big tech bros have developed, but as much as we can control, you know, publishing our data sets, publishing the work that we've done to show what we've looked at, what biases that we've tried to address. And continuous monitoring. So we can get this term called regression to the mean, but we can also get biases being introduced over time. As populations change, then sometimes our model that we trained on one population over time, it changes. And so we need to make sure that we are, you know, checking and looking for these as we move forward. So I'm just going to, for like 5 minutes, and this is just a spin through because I am not a legal expert, but I think it's just worth being aware of health policy regulations that are available globally and that can talk to these kind of things. So the WHO has a framework for ethics and governance within AI. And this talks about encouraging member states to adopt policies that prioritize human rights, safety, and equity. And it talks about it talks about this concept of AI supporting but not replacing humans. And it talks about transparency and mechanisms for oversight. It also, WHO talks about equity. It talks about the equity factor, making sure that everybody has the bike that fits them. Everybody has the AI that they can access in the way that they can access it. The European Union is probably the strongest data protection regulation under the GDPR guidelines that you may have not heard of. And this really sets a global standard for data privacy and AI. Now, it influences many countries beyond Europe. The Trump administration are not very keen on GDPR. They feel that it limits the growth of AI and AI development. But really, this is a political and economic, decision where different parts of the world are approaching this in very different ways. In the United States, if you want to use AI in medicine, there is the FDA, who is the regulator of medicines, has an action plan where they are regulating AI as medical devices. And so you have to show that your AI meets rigorous safety, efficacy, and ethical standards. But actually, it's really quite vague on what those rigorous safety, efficacy, and ethical standards are. But you can read more about it if you like. In Africa, South Africa is probably doing better than the rest of us. They have a Protection of Personal Information Act. In other countries in our part of the world, so Kenya and Uganda, have data protection acts that really are not AI specific, but they do talk about data protection. There's also Pan-African things. There's an African Union data policy framework and a Pan-African Health Organizations initiative. I'm going to a conference in Cape Town with Vicky actually next week. And within that, there may well be more guidelines that come out for AI for Africa through the African Union, and we will report back if they are. So just to finish, I just want to talk about a little bit about some research that we did in the HASH project, where we talked to people about what they thought that AI was going to do. And, there were big discrepancies. Some people were saying it takes a long time for communities to appreciate AI. Some people say that these AI tools are not for ours, they're for Bazungus, that Bazungu are white people. People are worried that, there is no phone network. So how can we even talk about internet? Why are we worrying about these things? Why are we worrying about AI when we don't even have phones? People say that we should leave AI to be tested first in animals. That's going on a very biomedical thing. We test drugs in animals. Why aren't we testing AI in animals first? But then some people are saying, well, look, if I go to the health center and I don't find my friend Stella, my nurse Stella, I may not be treated well. So why don't I just talk to the AI that's always going to treat me really nicely? If it treats me nicely, why wouldn't I then talk to it? And then, there are people that are saying if we package the AI well, people can really buy into the AI and people will be interested in supporting these innovations. And the reason that we've got this quote, the whole issue rotates around who's going to be the user of AI, is I hope that you can maybe see in the background, there's this road, and on one side of the road, there is this unregulated housing and these small, tightly packed, low-income housing. And on the other side of the road, there are these posh houses with these big gardens. And really what this is trying to show is that, AI shouldn't just be about people on the right-hand side with their posh houses. It should also be for everyone, but we need to take everybody with us and we need to listen to people's concerns and we need to listen to their challenges. So thank you very, very much. I'm so sorry that I've had some technical issues with the presentation, but I hope that didn't affect your understanding. And maybe we can go, if we have time, Vicky, we can go through some of the questions. Oh, so there's a nice comment. My takeaway is when thinking about AI fairness, always ask who benefits if the bias remains and who pays the cost. Absolutely. That's a really good takeaway. Like who is challenged, who really doesn't do well if there is bias in the system. Should I go up, Vicky, and see if there's any questions?
There are a couple
Yeah.
of questions.
So that's ground truth registration links. So what are the practical tips to achieve fairness in AI? So I think there's a slide in there which has some more practical tips. I think in terms of the actual coding and addressing bias within data sets, the practical bits of that, Victoria, are we covering that in a session coming up?
I think so.
Yeah. And so the actual the ways that we can manipulate data sets, create synthetic data, try and balance our data sets in we can add extra data for women if we need to, reduce data for men. Those are specific technical things that we can do. How do we balance between creating inclusive systems and generating two general systems? So I'm going to give you an example of something that Vicky and I are working on, right? So we're working on a kind of multi-country conversational agent for sexual and reproductive health. And our approach is going to be that the nuts and bolts of this, the coding, the platform, the foundational model, all of those things are going to be the same. But what we are going to do is create a framework and a guidebook so that people can take this system and they can follow a certain set of steps. So, for example, adjusting their data set, adding in local languages to their data set, adding specific SRH languages to their data set, adding maybe GPS coordinates of health centers, so that they can go through and adapt this general tool to their specific population. So I do think there are ways of, having something that's created, having a model that's created, for example, Caesar's model for breast cancer image analysis. The foundation model is there, the systems are there, but then when we take it to a new population, we train it with data and with information from that new population so that we are refining it for that actual population. And I think that there are ways of doing that, whatever different AI that we're using, ways of adapting it to the local context. So I don't think we will end up with general systems. I think the inclusivity is making sure that the tools are for that particular population. And if we need more than one tool, then that's okay. We shouldn't be thinking that one tool will fit everyone. So how do we solve and reduce these biases, especially in global south and rural women? Okay, so it depends on the population, and we really need to think about different things that we do. So, for example, our colleagues in Ghana, or I'll give you an example, they are working with deaf adolescents, right? And they are developing a conversational agent. So what they did was they went and interviewed these deaf adolescents using sign language. And it's Ghanaian sign language. It isn't even an international sign language. It's very, very specific to them. They interviewed them. They understood what gaps they had in their knowledge. They tried to understand where they were getting health information from already. They understand what kind of challenges they had accessing healthcare and what information that they wanted. So they really went and worked with that community to find out what they needed. Then they developed a conversational agent using, data from LLMs. They got local doctors to validate it to make sure that it was correct for that population. And then, because they knew that some of these adolescents wouldn't even be able to work on a smartphone, they uploaded the conversational agent to computers in their schools, in their deaf schools, where they could have access to it. Now, what that is doing is showing that it's not just a silver bullet, that we can just do one thing and we solve this problem of the marginalized group. It is a very targeted thing that we need to do. And we're not going to be able to solve everything all at once. We can look at the population in front of us and think of ways that we can do it for those populations. one of the things is documenting people. We need to make sure that people are present in digital data sets. And that's coming at it from a different angle. When people in the global south, rural women, marginalized individuals, we need to make sure that they are represented in the data. Digitalizing health data, digitalizing other records, everywhere you go, thinking about how we can increase data with people. But this is a big problem. It's a problem that existed way before AI, right? We can be part of the solution, but what we mustn't do is make the problem worse. So we really need to think about this as we're going along. So patients are predicted. Okay, we've got true positives. I think that's talking about before. And then these are all your comments about what you guys are going to do. Okay, brilliant. So any further questions? Okay, sorry. As a medical sociologist, how do we solve and reduce these biases? Okay, I've tried to kind of answer that. It's really difficult. It's really difficult. These problems existed before, but there are ways, right? Can we not use AI to generate medical records? Can we not use AI to generate data? Can we record consultations of doctors and nurses? And can we use AI to just generate more data that can then be fed into our data sets? We have to be creative in this. And really, I'm not the person to answer these questions. You are the guys in the field. You are the guys at ground level. Everybody needs to be taking on this responsibility, and everybody needs to start thinking about what they can do to reduce the gap in health inequity, not inequality, health inequity, and not let AI perpetuate it. We must not let AI make these gaps worse. AI must not just belong to the rich who already have access to healthcare. And I'm going to stop right there. Thank you so much.
Did you attempt the one on emotional intelligence? It was right.
I think we talked about it at the beginning. How do we integrate? Is it safe to integrate emotional intelligence into artificial intelligence? It depends what you mean by emotional intelligence. If you mean copying empathy by using words that are empathetic, using words that make people feel comfortable, that kind of thing, then yes, but with oversight. But, there have been examples within mental health apps and within mental health AI solutions where actually things take a very dark turn. And in trying to be empathetic, the AI actually starts listening to people's desires to end their own lives and starts encouraging them to do that. So it can be dangerous. And this is where the oversight comes in. We can't just create these tools and then let them carry on unguarded. We need to be doing sampling of these conversations. We need to be checking on these conversations. We need to be alerting people and reminding people that these are not humans and that they are not healthcare practitioners. They are AI tools, and that they should be used synergistically with health professionals, not as alternatives to health professionals. So I think the whole emotional intelligence thing is a thorny issue because emotional intelligence isn't always positive. It can be negative, right? And so we just have to also just be very careful that at this stage in AI's evolution, it is not general human intelligence, right? It doesn't really know right from wrong. And so it needs to be monitored. It doesn't have a moral conscience. And so when we're talking about the emotional intelligence slide, there is a concern there. It doesn't follow a code of ethical practice that doctors and nurses and health professionals do. So we need to keep an eye on it, right? it needs to be under our control and not working autonomously without our supervision.
All right.